Welcome to the podcast of Practical Laboratory Medicine special issue on acute kidney injury. Practical Laboratory Medicine is a peer-reviewed international open access journal of Elsevier and publishing original research, new methods and critical evaluations, case reports and short papers in the field of clinical chemistry and laboratory medicine. I'm your host, Barnali Das, reviews editor of Practical Laboratory Medicine and lead consultant of Biochemistry, Immunology and Toxicology Division of Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai, India, and also executive member of AACC Scientific Division and AACC India Section Chair. Today, I'm delighted to host Dr. Joel Khoury as our guest. Dr. Joel Khoury is Associate Professor of Laboratory Medicine and Director of Clinical Chemistry Laboratory and Fellowship Program at Yale School of Medicine and Yale-New Haven Health. He is board certified by American Board of Clinical Chemistry and a Fellow of AACC Academy. He is currently serving on the editorial boards of Clinical Chemistry and Clinical Biochemistry, and he is also chair of AACC Committee on Kidney Diseases and on the board of directors for AACC. He recently served as guest editor for Practical Laboratory Medicine special issue on acute kidney injury. It is worth mentioning that Dr. L. Khoury also launched his own YouTube channel titled Clinical Chemistry with Joel Khoury that infuses science with comedy and is focused on improving laboratory medicine practice. So welcome, Joe.
Thank you, Dr. Das. It's a pleasure to be part of this, and it was a pleasure to be part of the special issue as well. Looking forward for this discussion.
Thank you. So we would like to know Practical Laboratory Medicine special issue is titled Advances in Laboratory Detection of Acute Kidney Injury. Can you please provide a brief definition of acute kidney injury for our audience before delving into why this topic is worthy of being highlighted in Practical Laboratory Medicine special issue?
Absolutely. So acute kidney injury, or AKI, as we like to quickly abbreviate, is simply a sudden deterioration in kidney function that typically happens within about 48 hours, sometimes more sudden depending on if it's after a procedure. It can be a common thing in intensive care units where up to 50% of patients in the ICU can suffer from AKI. And typically we detect by either following creatinine, which is a common biomarker used for that, or urine output based on the 2012 Kidney Disease Improving Global Outcomes, or KDIGO definition. Now, there is a problem. That definition was published in 2012. There's been a lot of developments since that time, including the first FDA-approved biomarker in the US, which came out in 2014. New definitions, problems with the old definitions that were discussed, that were found after a lot of studies that came out showing, some false positives with the KDIGO definition, and AACC coming out with its own definition in 2020, and the new studies, new biomarkers, and now we're also seeing artificial intelligence studies that are looking at detecting AKI better, even without biomarkers, and using even older methods and older or current techniques. So we're seeing a lot of changes in this field that really warranted being addressed in this special issue, since it's been a decade since KDIGO has been published, and we are aware that KDIGO is working on an update. So we thought this would be very relevant to have a special issue that brings the laboratory medicine focus and perspective, so that we can hopefully help inform and guide some of the new development and the guidelines that are going to be coming out soon.
Terrific. So like KDIGO or KDIGO, Kidney Disease Improving Global Outcomes Guidelines advise identification of AKI based on increasing creatinine. So is there any difference between AACC guidance document, 2020 guidance document, and KDIGO 2012 definition? So if you can briefly expand on that.
No, excellent question. Absolutely. So that is basically one of the major findings in the AACC guideline or guidance document that came out in 2020 was the fact that the KDIGO definition, which again has a definition for creatinine for AKI, based for AKI, and also urine output. So focusing on the creatinine, which is the most widely used definition because it's much easier to measure, it's more broad. What we've found is that that definition, which is essentially a change of plus 0.3 milligrams per deciliter in the US which happening under 48 hours, or 50% over 7 days is what they use. And for anybody who's international, that translates to 26.5 micromoles per liter change happening within 48 hours, or 50% change happening over 7 days. So that definition, based on a lot of studies, has shown significant false positives, especially in patients whose creatinine is greater than 1.5 milligram per deciliter, which is the upper end of the normal range. And so we see almost 31% false positives. So in most patients with slightly elevated creatinine or chronic kidney disease patients, it is a really bad definition because it triggers a lot of false positives. You have much higher variability. And the problem and why that happened is because that KDIGO definition was consensus-based, meaning that it was a group of experts, mostly clinicians, that did not include pathology groups, who came up with a definition that did not factor in the biological variability of creatinine on the high end. And also, it was too insensitive on the low end. So for pediatric patients with very low creatinines, or patients who may be amputees or who have generally lower level creatinine, like older women tend to have, it was not sensitive enough. 0.3 is a very large change for somebody whose creatinine is 0.3 or 0.4 or 0.5. So what we did as a committee is within AACC is we grouped together laboratory experts and nephrologists and reviewed the data on biological variability and analytical variability, and came up with a reference change value calculation that factors in all of that. And what we found is similar to what you do when you review CAP proficiency testing. You have a lower limit for the low end, and then a different percent limit. So you have an absolute limit for the lower end of the range and a different percent limit for the higher end of the range. So we essentially calculated two reference change values, one for creatinines less than 1 milligram per deciliter, which translates to around 90 micromole per liter based on the international unit. There we saw that the change of 0.2 milligram per deciliter, or which roughly converts to around 20 micromole per liter. And we're using rough because it's important to remember these are estimates. So we rounded so the numbers are easy to remember. So it's a 0.2 change or 20 micromole per liter if your creatinine is less than 1 milligram per deciliter or 90 micromole per liter. And that is 20% for the high end if you're over 1 or over 90 micromole per liter. And those definitions factor in the lower end of the range and the higher end of the range are based on biological variability studies that were done in chronic kidney disease patients and patients with lower creatinine values. And not only that, initially when we were writing this, we were actually linking it together based on these calculations. But in that time, as we were reviewing the data, there were studies that came out without doing biological variability studies, but that linked these changes to mortality and morbidity within 24 hours. So there are studies that we cite in the guideline. I urge anybody who's interested to review the document that link those changes to higher rates of mortality and morbidity related to kidney disease. So this can happen not within just 24 hours, it can happen even over a year. They're saying like long. It basically is overall linked, not just in the case of AKI. So we felt it's important within this document to highlight what is a significant change within creatinine, and that's how we've defined it. So for AKI, at least, that means a change happening within a short period, which could be 24 hours even. You don't have to wait to 48 if you're seeing that rise. And that is a major difference from the KDIGO, which was a consensus-based definition that did not factor in biological and analytical variability.
Excellent. So I'll recommend our listeners to go through AACC guidance document. And Dr. Joe, like small changes to serum level of creatinine, many times it's not detected by clinicians. So early intervention is unlikely. So as you mentioned about AI and artificial intelligence based on e-alert, so the ability to implement real-time AKI interventions such as e-alert or electronic alert in EMR, there are best practice advisories amongst clinicians or different nephrology groups. So this has emerged as a promising tool to fight against the harmful sequelae of AKI. So can we implement this 0.2 milligram per deciliter or 20% for electronic alerting, electronic medical record in HIS or LIS?
No, so that is an excellent question. So the studies that we've reviewed as part of this guidance document, and actually we have that is recommendation number 13 based on the guidance document, where we've evaluated also the utility of automated alerts. The problem that we saw is that the studies that looked at the effect on outcomes for using e-alerts, and that was actually done by one of our collaborators here at Yale, Perry Wilson, who compared the two groups. So in some, they got the alert and others did not. And they basically saw no difference in terms of outcomes and detection. And actually, at least in the academic center, but they also tested it in the non-academic center. And that's where it got interesting, because we had worse outcomes in the group that used e-alerts than not. So actually, there was harm for using e-alerts in the non-academic setting. Now, why did this happen? What factors are involved? I mean, for me, looking at this, the definition that was used was the KDIGO definition, right? They didn't use the AACC definition. I think that may be part of it, because what's happening is if you're stopping important medication that could, for somebody who needs it because it has a risk that they could develop an AKI for something that's actually a false positive, that can be harmful to the patient. So it's important to remember that we need to look at outcome studies for all of this.
Absolutely.
We should not just take it for granted that giving an alert is better, especially in an area where the definition is not quite right. Like, so we have a problem with KDIGO definition. And I think if somebody just implements that alert with a 30% false positive on the high end, you know, you're probably stopping a medication for somebody who needs it, and you may be harming them. So it's not so straightforward. And I'll say, at least to your question on, well, what if we implemented the AACC alert? I don't know. So that was part of because it's so new, we don't know. Nobody's done a head-to-head study with or without alert to see what is the effect on outcomes. That is something we actually make a request that is needed in the field. We need to study this further. So we actually say that, in our part of our recommendation, that the value of automated alerts, which has been very conflicting. Some studies found positive effects. Some studies found, like I mentioned, Perry Wilson here, found a negative effect, and actually it caused harm. And so I think, like, it's a very important to state that it's unclear that the benefit, at least today, with all of these factors. And so while we say that there is some evidence of improving clinical practice, it's not yet been linked to improved outcomes. So we are still looking for that. And this is why, at least here at Yale, we have not implemented it, because we had, and as you know, the experience with the study. And so we may be evaluating it again with the new guideline and see if that makes a difference, but there may be other factors at play. So this is still very much an area that we are researching.
Thank you. Thank you for detailed explanations. So this spatial issue in practical laboratory medicine contains several reviews that focused on emerging biomarkers of acute kidney injury. Can you highlight a few of those and how close they are to being used clinically? So like, I think I heard one of your talk, like you are searching for troponins for acute kidney injury. So have you, like, find any biomarker which is troponins of acute kidney injury?
So, to answer that short and quick, the answer is no. We have not found a troponin equivalent for the kidney. And that's simply because the kidney is very different from the heart. And in fact, most of the markers we follow are in urine, which is urine, as you know, is a very difficult matrix, because the concentrations in urine can also reflect hydration status, are affected by a lot of other variables, and that are not as tightly controlled as blood. So you end up with a lot more problems with measuring biomarkers in urine. So the main biomarkers that are showing up in the field, so the one that is FDA approved, and it's the only one as of today, is TIMP2 IGF-BP7, which is also commonly called NephroCheck. And the other one that's leading elsewhere worldwide is NGAL. It has not yet been FDA approved. And the third is IGF-BP7, which is basically, oh no, actually I mentioned that. So the third one is, so I mentioned TIMP2 IGF-BP7, NGAL, and LFABP, sorry, so liver type fatty acid binding protein. So that LFABP is only approved right now in Japan. It has not made its way to any of the other countries regulatory wise, but we decided as a committee, since this guideline is focused on initially in the US, so we decided to focus on the one that is FDA approved. So we have not reviewed or provide any feedback on NGAL or TIM2-IGF-BP7, or LFABP, but we provide feedback on TIM2-IGF-BP7 or NephroCheck. So what we've seen, at least looking at all of these biomarkers, is even TIM2-IGF-BP7, which is in studies head-to-head with all the other markers, showed that it's most promising and best. It has a very high false positive rate as well, which even in the FDA letter that approved it said, clinicians should be aware that there's a 50% false positive rate. So if you take a healthy population, 50% of those will test positive by this test, which is why it is not widely used in our clinical setting, and there hasn't been a request to add it. And some people have advocated for its use in specific settings, because how do you advocate for using, or how do you make a test better with such a high false positive rate? You basically test it in patients with high risk for AKI, because if you're testing high risk for AKI, it means you have less healthy people, more disease. It performs better in that setting. So it's very important that when you're evaluating these biomarkers, that we are looking at the incidence rate in the population being tested and making sure that matches the population we're eventually going to use this test in. Which is why I say, if you're using it in a very niche setting, patients that are high risk, some may argue if you're that good at categorizing people high risk and low risk, then why test at all? And simply you can just reduce the nephrotoxic medication that's used in that population and act as if they're going to develop it. So in summary, it would be very bad if this test is approved and all of a sudden started being used as troponin widely on a lot of patients to evaluate for MI, because it has such a high false positive rate. Many are trying to evaluate its use in the specific risk population, but so far it has not shown positive effects, in terms of clinical outcomes. So it hasn't shown benefit when being used in these settings versus not using it. And that's key. So far, our recommendation from the guideline was we do recommend not using TIM2-IGF-BP7 at this time, because it hasn't shown any effect on clinical outcomes. And the research that is published in this issue has been furthering and showing the new studies that have come out and what have they found. But so far, that is still holding true, that, at least the TIM2-IGF-BP7 haven't shown significant effects on outcomes. They're still being explored further. For NGAL, I'll say, because that's been covered in the special issue as well, we've seen better effects in the pediatric setting. It sounds like there may be some use there that may be possible, but again, we're still waiting for FDA approval, and we still haven't seen the full breadth of those studies yet. So it's an interesting area that continues to develop, and we'll continue to monitor. We're hopeful that, we may not have a troponin equivalent, but we may have something that at least is still useful, at least for us in a hospital setting in some of those high-risk patients.
Absolutely. Thanks for highlighting those new biomarkers, NephroCheck and other biomarkers, NGAL. Many countries actually are using NGAL and NephroCheck. So I think that will be very much beneficial for them to follow some guidelines. And so there were also few articles focusing on the role of creatinine in diagnosis of AKI. So can you elaborate on their findings in practical laboratory medicine?
Absolutely. So I'll focus on two articles here. I mean, creatinine is obviously the old marker that we've all been using for a very long time, but somehow it keeps demonstrating its increased value over time, and especially as our understanding of what AKI is evolving. So the two studies that came out in this, especially one is by Gorelick et al. They used large data analysis to demonstrate how monitoring creatinine day to day, those changes among inpatients can help identify radiocontrast-induced nephropathy. The other study, which is Ivica et al., reviewed the performance of using e-alerts, which we just talked about, so electronic alerts, to alert a physician based on certain changes in serum creatinine that are measured in the clinical lab, and its ability to improve clinical outcomes. And they both nicely summarize the problems with the current approaches used by institutions who have tried implementing e-alerts, but had unfavorable outcomes, and then provide key recommendations to improve their performance. So what's nice about especially the Ivica et al. Paper is like they're summarizing why they think some of those studies that have implemented the alerts have failed, which is an important lesson for anybody who's trying to either evaluate future development and future use of those, or those who are currently using it to take into consideration.
A few other articles focused on urine as a testing metric. So can you summarize their findings?
Absolutely. So urine is as I mentioned already for the NephroCheck and Engel, it's another very important testing matrix. Some call urine, liquid gold, especially in the setting of nephrology, because that's where the information is when you're looking for kidney injury. Because you can find, especially at the site of the kidney, it's the closest to the kidney and what the kidney is producing. So you can tell a lot of structural damage to the kidney can be detected there. Or some of the biomarkers that we measure, like creatinine, when you're looking for functional changes, many of them can also be detected there. So it's an important testing matrix when we're evaluating AKI. And Tran et al. In our special issue demonstrated the importance of measuring urine albumin, dipstick blood, and urine uromodulin, which is another emerging biomarker, to differentiate glomerular from tubular interstitial diseases. While Honig et al., who presented another case, used a case-based approach to highlight the importance of using manual urine microscopy in patients with AKI to improve clinical care. So urine has a lot of potential, not just in biomarker measurement, but especially in manual urine microscopy, or we're hoping automated becomes something of the future. We're seeing a lot of developments in that area, but to help distinguish even the type of disease that is developing. So there's a lot of promise, and we think urine will probably be the key matrix where the future of detecting AKI earlier will happen.
Thank you for elaborate discussion on this. So can you explain the significance of findings from Dr. Jones and Chung's article regarding biochemical testing affected in patients with AKI?
Absolutely. I really like this one because Dr. Jones and Chung basically studied the effect of these acute changes happening in glomerular filtration rate. As happens with AKI, you have the sudden change of GFR on common biochemical tests. So they basically asked the question, how do these other chemistry tests, which they looked at 28 of them, change with AKI? Because if you think of chronic kidney disease, we all know, in these patients, you start have higher, because you have more retention, you have higher values of certain proteins, certain analytes. Even the best example I give is troponin, going back to the one we already mentioned. With CKD, we know with patients you can have a higher baseline troponin because they retain more protein, so naturally their concentrations is higher. So with Jones and Chung et al.'s paper, they looked at, okay, let's look at that in AKI. How are these 28 tests changing when you have AKI? And what they found was 7 of the 28 had significant changes, while 21 did not. And those 7 were serum urea, phosphate, urate, PTH, or parathyroid hormone, troponin T, which we already know again from CKD, beta natriuretic peptide, and now we more measure NT-proBNP, which is another part of it. So most labs now measure NT-proBNP instead of BNP. So these changes are happening in these patients with AKI without any comorbidity or concurrent change in actual clinical status. So it's important that clinical teams interpreting these results know of these changes happening within patients who have AKI, so that they don't misinterpret those blood tests involving these analytes. And I think that's a pretty significant finding and helpful to for the lab community to look at this and try to see how do we explain these changes to our clinical teams for those patients so they don't misinterpret them.
Thank you. Appreciate your overview. And what is your take-home message from this special issue on AKI?
So if I was to summarize the major developments in the field, I'd say it's important to remember that we've come a long way since the decade where that 2012 KDIGO has been published, and we hope that what we've found so far informs the next guideline. And what I see as the main changes are the new definition that we've talked about, the AACC 2020 criteria. Also, the new biomarkers. It's important to remember, new is not always better. We really need to show effect on outcomes. So just hearing something, learning of all of these structural biomarkers, when people have tried to test and look for effects on outcomes, they have so far failed. So it's important to remember, look for the evidence and do not just fall into the hype or the marketing of certain tests. So that's my summary for the biomarkers and the definition. Third, I'll say we're really looking at electronic alerts, the same as biomarkers. There's a lot of promise. It sounds like a good idea, but so far it's in the implementation. Something is not looking right, and that needs to be addressed before we can implement it safely. Because again, there's been evidence of harm in some studies. So it's important to figure out why that happened and what happened. And lastly, I'll say the frontier that I'm most excited about is artificial intelligence. So more and more papers are coming out in this space that have shown that artificial intelligence has had better performing characteristics as measured by areas under the curve than biomarkers. Like their AUCs were on 0.9, which is exceptional and showing that, we may not need biomarkers, and maybe the ability to detect AKI has been sitting right under our eyes. We just didn't have the intelligence or the artificial intelligence to see it. So with artificial intelligence, you can use existing parameters, existing changes, and it doesn't care about any definition for AKI that we come up with. It finds its own criteria. So that it tells you this patient's going to develop AKI. So it's independent of what we define and what we try to make nice, like KDIGO or AACC. So to me, that is probably the future of AKI detection. It may be AI. It's just not easy to implement. There's a lot of regulatory issues we need to account for, and also it requires careful validation. So with all of that, I'll say it's an exciting field. This issue just shows the changes that we've seen in the last decade, but there's probably going to be a lot more exciting ones to come in the next that we can hopefully implement that will help us advance the ability to detect AKI.
Thanks so much, Dr. Joel Khoury. I very much appreciate your time to explain all these concepts to our listeners today. I'll request everyone to read the special issue on advances in laboratory detection of acute kidney injury in practical laboratory medicine for more details. Thank you.
Thank you, Dr. Das. It's been a pleasure.
Thank you so much.